Let's welcome Jocelyn to the podium so she can give us a pharmacist perspective on preventing and treating obesity. Thank you.
Good morning, and thanks for everyone's attention, and thanks to the Alliance for offering this opportunity for me to speak today. A little bit of what I was going to start with is some items that John touched on, so I'll just kind of breeze over those. But we know that obesity is problematic in the United States, and obese patients cost us more. In my role currently, a lot of employer groups that I work with state, well, I'm not going to cover weight loss medications, I find those cosmetic, or I don't cover them because I haven't covered them in the past and I'm not planning to start covering them now. I didn't account for that extra expense. And so we have medical expenditures related to obesity, as well as some of those productive costs associated with presenteeism or absenteeism as well. And it's not surprising that we find obese patients cost us more. This data is very old, from 1998, but even back then, as part of the NHANES, or the National Health and Nutrition Examination Survey, the details aren't necessarily important, but among both men and women, the graph on the left, as BMI increases, high blood pressure increases. On the graph on the right, among both men and women, the risk for high cholesterol increases in general as BMI increases. And so really, with this information, we know that high blood pressure and high cholesterol lead to chronic medical conditions, and so what can we do about it? And what have we been doing for the last 20 years? Why are we so slow to respond? Sorry about the little boxes there. But anyways, obesity, what are we going to do about it? Our treatment is going to be driven by the BMI, something that doctors are regularly assessing in the clinics, and often included as part of a wellness or health screening that's incorporated into worksite wellness programs. We have kind of three different options: lifestyle modifications, drug therapy, which would be my area of expertise, and then bariatric surgery. And then the intensity of our intervention will be driven by the BMI. And so patients in that BMI range of 25 to 29.9 is considered overweight, and those patients, clinicians should be recommending lifestyle modifications. Patients in the obese category of a BMI of 30 to 39 or a little bit lower with comorbidities, and these comorbidities can really be any medical condition that could benefit from weight loss. Diabetes, high blood pressure, sleep apnea, arthritis. Those patients would qualify for lifestyle modifications as well as drug therapy. And then patients in the morbid obesity or severe obesity category of a BMI greater than 40 would qualify for lifestyle modifications, drug therapy recommendations, and bariatric surgery. Bariatric surgery will be the most effective intervention, although less than 1% of patients who qualify actually undergo the surgery, and that could be due to coverage, access, or their personal preferences. The percentages listed below each of the different interventions is the average percent weight loss associated with each. So you might make some ground with lifestyle modifications, but for some patients that won't simply be enough. So really that combination of lifestyle changes and drug therapy can help us achieve a more meaningful weight loss goal. Nothing really new on the lifestyle modification front. Interesting, there's a lot more research on the behavioral therapy type lifestyle modification, which would include counseling as well as exercise and diet education and support, and really more of a high touch point program, multiple touch points per month. This would be considered a short-term program, and if someone has success with that type of program, really transitioning them more to like a Weight Watchers, once a month type check-in, long-term weight maintenance program. I think as a clinician, it's important that we educate our patients the rationale behind these lifestyle changes, why it's important for you to lose weight. It will lower your risk for diabetes, or it could improve your diabetes, lowering your risk for heart attack and stroke, and engaging patients. This is easy these days with all the different wearable technologies, the different apps for your phone. People can really set goals, set out to achieve them, compete with their friends, and really generate some healthy competition there. When we think about drug therapy, we'll certainly touch on more specifics about the medications in just a minute. But the medications, we don't have a ton of options, but there's certainly been some recent developments in the last couple of years. I would advocate for covering these type of medications on your insurance plans. While they are mostly branded medications and they are a little bit costly, we can control costs and minimize abuse by using utilization management or requiring prior authorization, ensuring that the patient really is meeting those BMI targets outlined by the medical societies out there before we're paying for these type of therapies. we should be monitoring progress. If patients aren't achieving weight loss in 12 weeks' time, the therapy should be discontinued. It's unlikely to be effective for that patient. And these items can be used short-term or long-term. Some patients may need them to just maintain healthy weight over a longer period of time. But some of that will be controlled through that prior authorization process. You're not just kind of opening the floodgates for indefinite coverage. We need to evaluate each year, what's their BMI, have they made lifestyle changes, things like that. Unfortunately, when people don't have access to the medications, they might turn to supplements. These things are widely promoted, easily accessible. Quite frankly, there's not a lot of data to say that they work, and they might have untoward consequences for our most high-risk patients, those that are overweight, have high blood pressure, high cholesterol. These things could exacerbate some of their medical conditions. As a clinician, we want to be cognizant of other drugs that a patient might be taking that could be promoting weight gain, especially among our diabetic patients. There's some drugs associated with weight gain. Really, we should be looking at globally, can we get these people onto weight neutral or weight lowering medications? And then if we do have patients who have had bariatric surgery, after bariatric surgery, patients can only take medications the size of an M&M. And so they're going to need adjustments in their medication regimen. They might need vitamin supplementation. They might need more frequent monitoring of their medications depending on what medications they're on. And so, especially in the immediate postoperative period, patients will need adjustments to their medication regimen. So we'll talk a little bit about the different treatment options. We have 6 oral treatment options on the market today, and I'm only speaking about things that are FDA approved for weight loss. There's certainly lots of other items that are used off-label. The first 2 items on the chart have been on the market since 1959. They're quite old, they're pretty cheap, and they work fairly well. They alter brain chemicals to reduce appetite, and dialpha-propion and phentermine are the 2 names. They are both controlled substances. However, there's most of the literature surrounding the abuse potential with these medications is kind of mixed information. It's not necessarily well supported. In general, patients might have mild withdrawal symptoms if they stop the medication abruptly. These medications are only approved for short-term use, less than a year's time period. And the trials were certainly not as robust that were those done back in the 50s as they are done today, with clear outcomes and thresholds for approval. And so these medications, the effectiveness data listed here is really based on pooled studies, various patient populations, and smaller in size. But again, these medications are pretty cheap. Patients in general would still pay for these type of medications even if not covered on the insurance benefit. Then we kind of had a very dormant period with no new treatment options until the early 2000s. And Qsima came out on the market in 2012, and I have it on this page because it contains phentermine, one of the drugs we just spoke about. Phentermine, back in the 60s and 70s, was combined with another medication and formerly called fen-phen. There's lots of news articles about that, and it was pulled from the market back in the 90s over some side effect related concerns. Phentermine remains on the market, but what we've done here with Qsima is taken it and combined it with another medication used for seizures and migraines. And in those trials, we found that patients lost weight. And so, not surprisingly, the drug companies don't have to do much work here. They just take 2 drugs that are already on the market, combine them together. We know that they cause weight loss, and put them into one convenient pill, which again is altering brain chemicals to reduce appetite and cause weight loss. And people do pretty well with it. On average, 9 pounds lost over a 12-month period. And you will see weight loss in the first several months, and then over time, it's more of a maintenance, not necessarily additional weight loss over time. Hopefully during that time, patients are adjusting their habits and making lifestyle modifications, which will carry them into the future. 70% of patients in the trials involved with Qsima met their weight loss target, which is usually 5% weight loss. You'll see, though, that there is a little bit higher price tag associated with this medication. And the controlled substance status is just really related to the presence of phentermine. The next couple options, Contrave is the newest to market drug, approved in 2016. But again, nothing really new here. We've taken 2 drugs that we already use for other purposes, combined them into one pill, charge a lot of money for it, and we're altering brain chemicals to reduce appetite. Not a controlled substance, but doesn't work as well. At that 1-year time period, patients are losing less than or equal to 9 pounds, and less than half of patients are reaching that weight loss goal for the same price as the Qsima that we just talked about. Valveek was also approved in 2012. It works a little bit differently, but still altering brain chemicals to promote fullness, reduce appetite. It is a controlled substance because at high doses there were symptoms of euphoria observed. Patients losing a little bit less weight over the 12-month period compared to some of the other items we've talked about. And again, less than half of patients reaching that 5% weight loss goal, carrying a similar price tag. And then the last medication is available under 2 brand names, Xenical or Ali. Ali is the over-the-counter version offered at a lower dose, approved I think in 2006. Xenical was approved in 1999. So between the 50s and 1999, we really didn't have any new treatments, despite everyone, portion sizes increasing and everyone gaining more weight. This works a little bit differently. It alters fat absorption from the diet, and patients who don't adhere to a low-fat diet usually will not tolerate the medication. Comparable efficacy to some of the other products we've talked about, but up to half of patients reaching that 5% weight loss goal. The 2 prices there, the top one is for the prescription product, and the second price for $1.50 per day is for the over-the-counter product. I'm not sure why you wouldn't just double up on the over-the-counter product, but that was kind of an afterthought after I put the slide together. The final option would be an injectable medication. Looks quite similar to an insulin pen. It's called Sexenda, and it really alters hormonal signaling and reduces appetite in that manner. Weight loss is the greatest of all the options we've talked about so far. And again, approximately 50% of patients reaching that weight loss goal as outlined in the trial. In this case, it was a 4% weight loss target. All the others were a 5% weight loss target. You'll see the cost is substantially higher though. And I suspect the rationale for that is this medication is also approved under a different name called Victoza for diabetes. And so the ideal patient for this type of medication is an obese diabetic patient. And you'll see reductions in the need for other diabetic medications, perhaps insulin, when someone starts this medication. And so the reason that I really advocate for covering these type of medications, while we have mixed efficacy and not a lot of options available, we have a lot to gain if we can get somebody to reach a 5 to 10% weight loss, and that's achievable through the use of these medications. There's even benefits at 3% weight loss, but clinically meaningful weight loss is usually considered 5 to 10%. We can see reduced risk for diabetes, reduced risk for heart disease, improved cholesterol, improved blood pressure, improved severity of sleep apnea. And so really I would argue that there's something to be gained by covering these items. Certainly how defeating would it be if you've engaged with your doctor in your 1 30-minute visit per year, you've decided to make some lifestyle changes, then only to get to the pharmacy to find out your medication's not covered. I wanted to give a little bit of a perspective on what I'm seeing in the marketplace. So I work for National Cooperative Rx. We are a non-for-profit pharmacy benefit purchasing coalition right here in Fitchburg, but we do cover or service clients nationwide. We work 180 employer groups and have about 285,000 covered lives as of the first of this year. I looked at data from 2017. 26% of our employer groups are paying for these anti-obesity treatments in 2017, yet 80% pay for topical acne creams, which is something I would consider even more cosmetic. And so
when
really,
you say they cover, are they covering all 6 or 7?
Of the medications? Usually, yes, they would be, it's kind of like you turn the class on or you don't cover them.
Okay.
And then you could elect to put prior authorization in place. There certainly might be formulary management that not all of the options would be open to people since the mechanisms are kind of similar between the different agents, but in general, I just kind of looked at who had spend in these categories.
Okay.
Yeah. And so really we have an unmet need. This is a little bit hard to read, but there's 86.4 million adults in the United States with obesity, and this was as of 2011. And less than 3% of those are taking a medication. Now certainly they're not appropriate for all patients, but access is really the first step. So I would argue and advocate for access to the medications as, as a means for patients to be able to reach towards those goals. But lifestyle modifications won't be enough for everybody, and while we do have mixed efficacy, we can use our prior authorization criteria to manage costs and prevent abuse and really just give that opportunity to patients who are looking for it. So with that, I would be happy to take any questions. Sorry, I'm a fast talker sometimes. Yes?
Of your groups that do allow that, so of the, I think 26%, What would you say is the percentage of those that have a PA in place for them?
Almost all.
Okay.
And, you know, the PA criteria are going to vary from pharmacy benefit manager to pharmacy benefit manager, but really we work with CVS Caremark, and their criteria is going to be driven based on BMI. And I looked at like Wisconsin Medicaid, and you know, they have a box even on there, is the patient actively participating in lifestyle modifications? And really I would argue that that should be part of the criteria. We shouldn't just start with medications. And sometimes patients that want to pursue bariatric surgery, they might need to try a medication first before they'll even be taken to surgery. Thank you.
Thank you, Jocelyn.